Dear colleagues, welcome to ESC TV. My name is Boldizsar Kovacs from the University Hospital of Bern, and I have two esteemed guests with me, Professor Serge Boveda from Clinique Pasteur in Toulouse, and Professor José Cabrera from the University Hospital of Quirón Salud in Madrid. Welcome.
Thank you.
Thank you.
Our topics today are three. The EHRA project, the Simulation Village, and cardiac anatomy. Let me start with you, Dr. Boveda. Can you tell us about EHRA? What is EHRA?
Okay, EHRA is a novelty. This is the European Research Simulation Institute. It is a structure that we have created in order to optimize the training, especially of the young generations, to the novel ablation technologies. Also for devices or ablation, I think that it's very important to have simulation included in the curriculum for training, because it gives a first step before going to the lab with a real patient. This is more or less the philosophy. We are creating modules that are dedicated to special operations, and generally there are 3 days that are organized around a special operation. The first day is more the theory, addressing how it works. The second day is only simulation, and the third day is in the lab. This is very, very, very practical.
Can you speak on what topics are covered in these EHRA sessions, these 3-day sessions?
Well, for the moment, we have started with, this is just the beginning. This is the first year we are starting these courses. We are starting with LBB pacing. It will be the end of this week. We have also sessions on epicardial ablation. We have also sessions on AFib single shot ablation, essentially PVI, single shot. We have also sessions that are around 3D ablation with different systems. So we try to open to the most of operations that we have in our field. But again, this is just the first year. We can expect for the next years more modules that will be prepared.
Okay, thank you very much. Now, one more question that's going to be important to our audience. How is it funded? How can people access the content, and how can they be part of this project?
This is a very important point. We went to the EU to get a specific grant to start the project, but we have also a very strong relation and partnership with many companies that are interested by the project. So they are also funding in some parts the project, but at the base it's an EU project funded.
Okay, thank you very much. Now, if I can move to Dr. Cabrera, so our topic today is anatomy. Can you talk us about what workshops you offer at EHRA and throughout the year for cardiac anatomy?
Okay, during the last 4 years, from Barcelona to Vienna, Berlin, and promoted by Serge in the committee, we initiate this workshop with cardiac anatomy using post-mortem human heart. We translate into clinical practice the different anatomic landmark at the different gross morphological features that you need to take in your mind before, during the procedure, during an ablation procedure, during patients. Many years ago, we were using just the fluoroscopic position of the catheter, using the cardiac silhouettes, and now we are improving our imaging tools with the navigation system, intracardiac echocardiography, but doesn't matter. We need to have the anatomic landmark in our mind. You only are going to recognize that you know that exists, and this is crucial for anatomy. Then I'm very happy, I enjoy, because the group of people that go to the sessions are different age fellows, but also people that have been practicing cardiology during a long time. And the topic every year are different. In cardiac, we focus in different landmarks. For example, this year we focus more in VT and ventricular tachycardia in terms of the different arrhythmia substrates of the ventricle. I think this is people are enjoying these courses.
Absolutely. If I may, I think that what you are doing, Jose, is extremely important, and is going in the same direction of the Harris Institute, because anatomy is the basis for ablation and for also device implantation. So we are also thinking about implementing the courses of Harris with anatomy specific courses dedicated to the different operations that we are preparing. I think that the anatomy is basis, and it's true that since you have implemented this in the EHRA meeting, it's having a huge success. All the workshops are completely full, and the attendees are really liking, and they want that you repeat this every year. I think that this is a very, very big success.
I think that this is crucial that I am not anatomist, pure anatomist. This is crucial that I am electrophysiologist, I am cardiology. Your point of view is translational cardiac anatomy. This is the crucial point. It's not to show one anatomy regions. It's just to translate into the clinical and into the implantation of the different device, into the ablation procedure. And also architecture is crucial.
Yeah. No, I can speak for myself. During my fellowship, probably the most beneficial sessions were always the cardiac anatomy, because you understand what you're doing, what's the movement of the catheter is, and how to explain if you have trouble getting to a certain area in the heart. Absolutely.
500 years after Leonardo da Vinci, doesn't matter. You are always with new structure, you are always learning anatomy.
Yes.
Every year, doesn't matter the age.
If you don't know anatomy, you cannot do this job. That's for sure.
Now, what would you say is the most common misunderstanding, misconception among electrophysiologists, and how does that impact the procedural failure or success?
I think that it's crucial to understand the cardiac chamber from a correct attitudinal orientations. The problem that we have, for example, is that we use terms like posteroseptal regions, and these are not posterior, and these are not septal region. These are inferior paraseptal region, right or left. We need to understand what's anterior, what's posterior, what's superior, what's inferior. It's the only way to translate into the clinical assessment. It's just to use in your mind what is the correct positions. You can use the anatomy specimen in your hands, you can move, and this is not correct attitudinal orientation. But at the end, for example, when you are doing intracardiac echocardiography, if you don't know that the pulmonary artery is anterior and superior in relation with the aorta, you are not going to understand correctly the anatomic relation between the right and left ventricular outflow tract tachycardia. Therefore, attitudinal orientation is crucial, and to use the correct nomenclature. Interatrial septum. Some people use this term for the superior interatrial groove or inferior interatrial groove, when the septum is only the fossa ovalis. Or there are many structures, for example, the papillary muscle. Papillary muscle groove the papillary muscle. We use anterolateral papillary muscle for the left ventricle or posteroseptal papillary muscle. These are superior or these are inferior. Therefore, attitudinal orientation to begin to use the correct nomenclature in terms of the correct position of the heart in the body.
You mentioned the architectural structure. Can you elaborate that? Do you mean the histopathology of the tissue, or what is to understand on the architectural structure?
Now we are using navigation system, we are using intracardiac echocardiography, and we are able to see the gross morphological features correctly. The ending of the pulmonary vein, I remember when we described the common ending of the left pulmonary vein into the left atrium, the pouch. This is easy. Now with the new imaging tools, what's the problem? The problem is not only the present but the future. People need to understand architecture. You need to understand what is the cardiomyocyte in relation with the interstitial space. People need to understand that the interstitial space we have cellular components that are fibroblasts and myofibroblasts on extracellular matrix that is collagen, because a scar is arrhythmia. And not only to understand the anatomy substrate by understanding the anatomy relation between the cardiomyocyte and the interstitial space, but also when you are going to use now in the present and the future imaging tool, magnetic resonance imaging, photon counting, you are going to be able to identify the connective tissue and the scar. But what is the scar? Interstitial space. What is the scar? Extracellular matrix. What is the role? Fibroblasts. I think we need to look in our learning, in our understanding to architecture.
Thank you. That's fascinating. I would love to talk about that further, but let me quickly switch to the Simulation Village.
Yes.
Can you tell us about how the idea was developed and what the reason was to develop this idea?
Look, this is funny. Since we are starting, we are speaking about the different aspects of the same problem: training, anatomy, training manually, simulators. The Simulation Village is the door to enter in this journey about training. It's most of the time here at the EHRA meeting, thanks to this opportunity, the first time the young EPs are discovering the simulation world, how it works, the machines, the tools that we can use for that, and it's a way to start this education. But obviously, it's not because you are having a workshop of 1 hour that you are trained for a technology or a tool. This is just the introduction. I would like to give you a few numbers. Here in this meeting, we have organized 80 workshops.
Wow.
For different approaches, different operations: epicardial, hybrid ablation, transeptal, device implantation, LBB pacing, 3D mapping. We had more than 300 attendees during these 3 days that had at least one workshop. These 300 and more attendees are now aware about what is the new way of training and educating. This is, I believe, a very good introduction for getting this journey with, for example, workshops of EHRA, the 3-day courses that are more complete, also for going to the anatomy lessons by José Ángel, etc., etc. I think that the Simulation Village has not been prepared and built to be a final story. It's just the beginning of the story. And this is the way that we wanted to organize this. And I have to say that, again, we have a very good cooperation with the different companies that are participating. They are providing the simulators. They are helping us to start this new training and educational journey, which is very important.
Yeah.
So, among the attendees of EHRA, who are the attendees best suited to participate in sessions in the Simulation Village? Are these only young EPs, or maybe even EPs who haven't started yet, or also more senior electrophysiologists?
I'm sorry, but I will give again a few numbers. During these 3 days, the registrations were mainly by young 70% of the attendees are less than 40 years. So we can say young EPs. I think that you are just at a limit, but we are a little bit above. They are coming from all European countries, even from abroad. So it's really very open to everybody, and it's very important also to have a diversity of people coming from everywhere. They are generally attendees that are starting their curriculum. So I think that it fits very well with the young EPs, and I believe that they are really interested by this. And a final word, we are asking with a small survey that we are providing at the end of the simulation workshop, and 90% of the answers are find this experience good or excellent. So I think that the answer of the attendees is very, very encouraging, and we are also decided to continue this experience with 90% of very good answers of the attendees. I think this is a very important information.
Okay, great, amazing. Dr. Boveda, Dr. Cabrera, thank you very much for your time. I really appreciate it. We talked about the EHRA project, the simulation villages, and cardiac anatomy. And with this, I would like to close this session. Thank you very much for your attention.
Thank you.
Thank you.